this notion of framing a story as an individual's problem, that their drinking water is bad, or this small cluster of folks have bad drinking water, or this one person can fix it if they just go ahead and pop for the bottled water and that's a problem solved. But it's not an individual problem. It is a regional problem. There are upwards of 1 million people who were exposed to unsafe drinking water in the Central Valley. The story didn't tell us that, and it didn't tell us that an individual can't fix a sewage system and a water treatment system. That has to be a public and policymaker decision, and that somebody private owns the water system in these communities. And so what does that private person get when they sell water to people, and how does an individual shift that? So we, and then you as journalists, have a tremendous role to play in reframing this story, and the solutions when that happens are potent. So I said before I was going to suggest to you some things you can put in stories that make a difference, that in addition to reporting those facts, you can ask in your story, why is this happening? That might be some historical context. And when it comes to health disparities and inequities, we've got a shameful history in this country. If you want to go into it, there's plenty of stuff you can talk about. Why does it matter to me, the reader? Well, that depends on who your audience is. If you want it to matter to an individual who you want to make better health choices, put that in your story. Tell them what they can do. You guys that were on the panel talking about stress, you mentioned these things that were sort of platitudes, but go beyond the platitudes and talk about what people really can do, which could be get involved in your local community and speak out, because although that takes up your time, it may well reduce your stress when you become your own advocate and join with your neighbors and recognize that you're not alone. And then when you're not the person who's impacted, because this is where I think we live, we have all these problems that folks like to say, well, that's your problem, that's your community, that's your neighborhood, it's your fault, you're not like me. And so I read the story and I, say, click my tongue and say, oh, well, too bad for you. But you can put in your stories why it matters to the rest of us. We've been talking about that a little bit, this cost-benefit analysis. There's a tremendous demographic shift going on in this country. If we don't involve ourselves in reducing inequity, those of them who are in the majority now, who will no longer be in the majority, are going to find themselves with a workforce, with a school population, with a set of neighbors who are not equipped to generate the kind of income, generate the kind of tax revenue, provide the kinds of goods and services that they will need in their old age. There'll be nobody to buy your house as you retire if there's no population coming behind that has a job that creates an income that allows them to buy their house. So you have to put that kind of stuff in your stories to make people care. And then what can I do to change it? The reader. What can the reader do to change the circumstances about the water? And you can put some of those things in your story. So real quickly, let me shift to some of the stuff I told you before, those of you that hear this here earlier. The organization that I work with, PolicyLink, is a national advocacy organization. We do lots of publications. We have lots of tools and resources on our website. And our recent publication is called Why Place and Race Matter. It's all about building healthy communities. We've done it in conjunction with the California Endowment. And it profiles 21 stories of communities across the state of California, and also one example outside of California, in New York, the Harlem Children's Zone, talking about in education, in workforce, in health, in food access, in transit-oriented development, in parks and open space, and a whole range of other things, what people are doing in their communities that is working to change these circumstances, to hopefully prevent, and in some cases remediate, the kinds of illnesses and health consequences that people are suffering. But those stories don't often get profiled in depth, if at all. And so I'm encouraging you as journalists to look at, please take these documents, take as many as you want. I brought a whole box full of them. I don't want to take them back. But we have other materials on our resources, and contact people, and academic studies. Whatever you need to prove your case is out there. And I know others in this room are doing the same thing. And in this report is an action agenda of what people can do to both in terms of things like political power and litigation and enforcing laws, what they can do, shifting public perception, but also in terms of some substantive topics that they can get involved in if they aren't already. Safe drinking water is one of them. Taking on an approach called a health impact assessment, which is a strategy that can be used with local governments to require that before a policy is passed, they consider what the impact of, for example, a development project might be on the health of the surrounding neighborhood. You heard somebody earlier today mention health in all policies. It's another strategy. There's a strategy called joint use for communities that don't have parks and recreation space. Let's use those school grounds that are locked up at 3 o'clock in the afternoon and all weekend. Let's open them up so people can have recreational space and opportunities. And a whole range of other things. Most prominent, I think, for us has been our work on health, and it is an exciting thing to watch both the federal government invest in addressing the question of food deserts where there's not enough access to healthy food, and I think the correlated problem, which we sometimes call food swamps. There's food, but there's very, very bad food, lots of it, and it'll kill you. All the fast food places and processed food places and the liquor stores where people get the pork rinds and the Cheetos and they wash it down with some Mountain Dew. That kind of circumstance can be addressed by some policy that is happening at the federal and state and local level. Here in California, modeled on a federal piece of legislation, we're about to see the rollout of dollars to attract grocery stores into underserved neighborhoods or to convert existing stores like those liquor stores into places that sell fresh fruit and vegetables. There are solutions. There are thrilling solutions happening all the time, but they're not getting the level of traction and coverage that they warrant or that they need in order for us to turn the corner to make sure that these gentlemen have enough leisure time to spend it with their families and coach the track meets because they have too many patients. We want to cut down on the number of patients that they have. Thank you.
Thank you. Now, very quickly, from anyone on the panel who wants to answer this, we're talking about improving the quality, cost, and access to care. How does the new health care bill, the so-called Obamacare, as some people like to refer to it, affect the quality, cost, and access to care? Is it helping to make it easier, better, or is it making it worse? And any of you can jump in there and tackle that one.
I think it's unquestionably on the road to making it better. It's not a done deal yet, and there's lots to fight about. You should understand, actually, in some ways, the two most important investments the federal government has made in addressing the cost and quality problem are actually not in the health care bill, but are in the stimulus package. And they're called comparative effectiveness, that is, to allow patients and doctors to get a better idea of what works and what doesn't. Why are we paying 3 times as much for this new hip joint? Is it any better than the old hip joint? And the investment in healthcare IT, so that finally the healthcare system can approach every other industry that uses information technology to make things cheaper and more accessible. But the healthcare bill is clearly mainly about giving people coverage. It's not universal. Lloyd and I agree we would like it to be universal. It's a big step in that direction. And it has basically everything that every expert has ever suggested might be able to get a handle on this cost problem. And I'm not smart enough to know what they are, but there are a bunch of things that over time with experimentation we hope can bring costs down. So there's no question in my mind that the bill, after having been passed and if implemented, will put us in a better place than we were before it was passed. It will need some tweaking, and it's by no means a perfect bill, but I think it's a good thing.
And I would just say ditto to what Mark said, but I would add this. There's no question we're on the road to better. Let's look at 2 of the things that are in the bill that we're experiencing right now. Statistics show that 1 in 5 Americans in 8 years will be over the age of 55. Statistics also tell us that of that 1 in 5, 75% at one time or another will have what gets characterized as a pre-existing condition. So one of the things that the bill addresses that is irrefutable in terms of its benefit on the cost side and certainly to the potential consumer is the issue of having coverage as a pre-existing condition. Secondly, the issue of children. We know that if we can impact and immunize and get children into the system early, that as they progress through life, just that fundamental infusion of what I'll call proper, appropriate care will impact their length of life. And then finally, and this is something that a lot of people aren't aware of, when your children hit the age of 24, for those of you that have children and you're insured, what happens? They're off the plan. They're off the plan. But one of the understated statistics that's never really talked about is the high medical costs related to college-age kids, whether that's through accidents, whether that's through other kinds of other things. And I just want to say, and this is my last statement because I know we're running out of time. If I had to aggregate what I think are the solutions, I think I can best do that by defining the problem. And this is going to be simple. I think there's two aggregate problems. One is underuse of healthcare services in this country. What do I mean by that? Each year, millions of Americans are receiving services that are unnecessary, which increases the cost and reduces productivity. Let me give you an example. 18,000 people die annually because they don't receive effective interventions. 21% of a study showed that 21% of the eligible Medicare patients who suffered heart attacks didn't get beta blockers. So that's underuse of the system. Now, overuse. Think about this. 85% of all of the Xanax, Halcyon, Prozac that is produced in the world is consumed in the United States. Think about that. Consumed in the United States. So that's where I get to this issue of overuse. And then finally, 1 in 7 of the largest health plans in the nation came together and did a 5-year study. And they found out that 1 in 7 of the hysterectomies that they paid for were unnecessary, completely unnecessary. So that's why I say we have an issue of underuse and overuse. I believe there's enough money in the system, it's just being ineffectively applied.
How do you get that changed?
Through what we're trying to do relative to healthcare reform. And I also think some individual mandates and accountabilities, insurance reform, and I think unfortunately, and this is the controversial part, we're going to have to up the consequences on self-induced bad behavior.
Boy, that's pretty controversial. Any questions from our audience? Up the consequences on self-induced bad behavior. So in other words, if you overeat or overdrink or oversex, then what happens?
That doesn't mean that you can't get health care.
You're going to have to pay more.
But what it means is that if I do it, I'm not sure Dr. Smith should pay for me to do it.
So in other words, you have to pay for it, more for it, or?
I think we've got to build a system that incentivizes accountability, prevention, keeps people out of the hospital, but forces people to some extent to take some ownership for their own health.
Tough one. Any questions? Yes.
My question was actually asked in Washington when Dr. Lewis Sullivan was there, and as it relates to those of you who happen to practice medicine and the need and desire to have more medical professionals. I believe the doctor here suggested that maybe we don't need a doctor to fulfill all of the clerical work that goes on. But do you see a day where the training is compartmentalized, or the period to be a practicing physician is shortened? Because as we looked at the statistics going forward, we're going to need more doctors. And based on the training period that it takes to get to that point, you're not going to have enough folk. in the time that you need to have them? And what do you do to address that?
Well, there is certainly, well, there's a shortage of physicians today based on how we deliver care. And particularly given how we have set it up in the U.S. and in many systems, the basis of care is primary care. And then primary care brings in specialists to support. Now, that I think is a very effective approach, and that's an approach we take in Kaiser Permanente, which leverages the skill set of the specialist. It also allows for education to go back and forth to the primary care doc, as opposed to systems or practitioners who have no really connection, no flow of information. We have an electronic health record that allows any provider to see all the care, all of the suggestions and diagnoses, et cetera, that are there, all medications, imaging, et cetera. So I think today's production of healthcare providers, i.e. physicians, is inadequate based on how we currently deliver care. There are lots of medical school programs outside of the U.S. Ross, you heard about on the radio, producing more medical students who come to get graduate studies here in the U.S. than any other school in the U.S. actually. There are several that are in the process of being formed now outside of the country, because I think it's a good financial endeavor as well. To your question about the time it takes, there have been systems that have attempted to look at shortening the duration. There's 6-year programs from the time you graduate high school to medical school, sort of rather than an 8-year traditional program, 6 years for undergraduate and medical school. There are probably 1 or 2 that still exist in the country, but it's never really taken off. When you look at the residency program training after medical school, 3 years sort of for the base programs, all the way up to 7 or 8 years. In some ways, that could be shortened. Is that system antiquated? Well, let me tell you what's happened from the time I trained, which was, and I'm sure Mark remembers, we would work 30, 40 hours in 2 or 3 days. Now there is an hour restriction on students, so they cannot be worked in the way we did. And actually we see some effect in the outcomes of how people are trained who finish 3 and 4 years of training today. So I think that actually works against what you would like to see, which is people be trained more quickly. I suspect with the current technology and internet, et cetera, there has to be ways that we could do it better. We could sort of squeeze the time a bit.
I disagree with your premise.
Okay.
Your premise is that we need more doctors. If I had told you 20 years ago we need more travel agents, if I had told you 10 years ago we need more librarians, that might have been right if you assumed that travel agents were going to continue to do what travel agents did.
Okay.
I do not assume, but the length of time it takes to doctor, to me, it's much more important to figure out what we're training doctors to do than how long it takes, because it takes 12 years. If it took 11, the time trained, biomedical knowledge happens so fast that the way we organize, deploy, and train everybody in healthcare is 20 years behind the biomedical science. So I'll give you one example and I'll shut up. When I was in training, it took a doctor to diagnose strep throat in a kid. You had to do the exam, talk to the parents, look at the nudes, look at the exudate, make a guess, and you got to answer in 2 days. Now, a high school graduate can do that in 2 minutes for $5. But our reimbursement system is such that the pediatricians try to block that because that's still how they get paid. So to me, the question is not how do we train more pediatricians. We know from lots of evidence the more doctors you train, the more they will do so as to produce income. It's not that they're evil people, but that's what happens. I would rather train fewer of them and have them doing the things that we need doctors to do. What we will need doctors to do 10 years from now is very different from what we needed doctors to do 10 years ago. And so the standard answer to there's a shortage of doctors, to me, is not let's train more doctors. It's let's train more nurses, let's train more patients, let's deploy doctors to do the things that we need doctors to do. It's a much less expensive solution to that problem, I guarantee. So that's not maybe the common view, but that's my view. There's no other industry that trains people to do things that the technology allowed them to do 20 years ago, but that's still how we're training doctors.